I'm Dr. Alana Yurkiewicz, and this is Hard Medicine. The U.S. has doctors, but not always where we're needed most. Doctors choose what to practice and where to practice based largely on incentives, a good salary, good working conditions, and a place they want to live. Today, these incentives all seem to point in the wrong direction. Why does the average primary care doctor make $287,000 a year compared to $526,000 for a radiologist? Why can a dermatologist removing a skin lesion be paid nearly double an internist spending 30 minutes diagnosing and treating a complex patient? Why do rural communities struggle to open and sustain residency training, even when they desperately need new doctors? Finally, who decides these financial questions, and what is it based on? True value for patients or something else? My guest today, Lawson Mansell, brings one answer: policy. Lawson is a health policy analyst in Washington, D.C., who works on changing the hidden rules that influence where doctors go. Many of these incentives, he points out, come from the government, meaning government policy has a powerful role in shaping the physician workforce distribution. As a doctor, I would not want to be deployed. But in this episode, we get into the levers government can wield to make these jobs more desirable. How do we incentivize medical careers that save the most lives? How can we get more doctors not being forced, but choosing to practice where patients' needs are greatest? Lawson Mansell, welcome to Hard Medicine.
Thanks for having me. I'm really excited to have this conversation.
You've written a lot about incentives and how primary care doctors in this country get paid compared to specialists. And I want to start there. To give a bit of background, before 1992, doctors were paid according to what was considered usual, customary, and reasonable. In 1992, the Medicare physician fee schedule was signed into law, and this created a system of payment called RVUs, or relative value units, which is a complex formula that takes into account a doctor's time, mental effort, judgment, skill, mental stress, and today that is primarily how doctors get paid. This, unfortunately, has still disincentivized preventive care services and chronic disease management that primary care does over specialty services. And you've written about an industry group that is giving the government recommendations on keeping RVUs up to date. Can you tell us more about this group and the implications and how primary care versus specialists get paid in this country?
Yeah, so first of all, thanks so much for having me. Really excited to kind of dive into this. I think being able to catalog the various incentives that are pushing prospective doctors from choosing sort of more lucrative specialties over primary care is really important because ultimately, like you mentioned, if we want more doctors in the kinds of specialties that we need to combat the specific shortages in primary care, psychiatry, and others, ultimately the incentives have to shift and there has to be money there that make those decisions worthwhile. I think this is probably the most important incentive, and I think a lot of people would agree, which is ultimately how much money can you make over the course of your career? And that's largely shaped by the values of the services that doctors perform. And Medicare is sort of the primary way in which those rates are set. Medicare sets rates, and those have strong implications for the private markets rates for those same services. And so, like you mentioned, one of the key groups that's sort of responsible for doing that is actually the trade association, the Doctor Trade Association, which is the American Medical Association. And they have a committee that you mentioned relative value units. And so the committee that they have is the Relative Value Scale Update Committee, which is essentially every year, this committee, which is colloquially known as the RUC, they essentially recommend scores that are then sort of adjusted by geographic variation to CMS to sort of update the RVU system each year to determine what the cost and Medicare's reimbursement should be on a service by service basis. There's sort of like three components that they consider. One is sort of the time, the expense. The second is expense to the practice, and then there's also they adjust for the malpractice liability costs. But the committee itself is actually sort of dominated by the specialty medical societies. There's only one seat permanently reserved for primary care, and 22 of the 32 seats are appointed by specialty medical societies. And as a result of that, or as a partially as a result, there's so many different uh, things that influence these decisions. But because it's dominated by specialist physicians, many would argue that it's at the core of why specialists tend to make more and are reimbursed higher than primary care. There's sort of going back to when these originally set, two things I'll point to that I would consider that are sort of flaws in the way that they make these decisions. One is they don't fully account for the time spent doing administrative tasks. PCPs just have a higher level of admin, dealing with compliance with EHRs, documentation, billing. And the second is that it emphasizes sort of episodic care over longitudinal care. And that's very wonky terminology. But essentially, it's the idea that every single procedure is on an individual level is valued higher. A good example of this is sort of a skin lesion removal, which is reimbursed nearly double that of a 30-minute primary care visit. And I think that's sort of a major incentive flaw in the system.
And I think what's missing from the formula for RVUs is patient outcomes, right? And patient value. It takes into account things like physician time spent, like you mentioned, minutes a dermatologist removing a skin lesion versus 30 minutes of a primary care doctor doing chronic disease management and prevention. It takes into account the skill involved or the perceived skill, based on the RUC's assessment, the mental stress, the effort, etc. But what seems to be missing from this formula is the outcome on patients and the value that is added to patient care. Do you think it's a problem with RVUs, or is the RUC responsible for updating those outcomes?
Honestly, I think the if we look at like where the buck stops, I think it's ultimately the role of policymakers. And so, one of the key, I think, data points to consider here is that when the RUC makes recommendations to CMS, CMS is in no way required to adopt the RUC's recommendations. Despite that, since 1993, the AMA reports that they get an average annual acceptance rate of 90% from CMS. So essentially, whatever the RUC, whatever the AMA is suggesting a service should be reimbursed at, CMS is simply agreeing and setting it at that rate. Now, some would argue that this is sort of that CMS is somehow doing this in concert with the AMA, that they're working together. I think it's not exactly a sinister reality. I think, in contrary, it's ultimately that the AMA has a large membership of doctors, and so they're able to get this data a lot easier. They do this through surveys, so that's how they get information about how long it takes to perform a service. And so ultimately, who has access to the most doctors and are able to do these surveys is ultimately what CMS is stuck with. So ultimately, it's about sort of how that survey data is brought, what the response rates are like, what the variance is like, to make sure that the survey data is actually accurate. And that's where sort of, you get into the Government Accountability Office, the GAO, has already flagged this, as well as CMS has flagged over and over that there's low response rates in these surveys, there's high variance, that they have concerned with the oversight of how they're being done, lack of transparency, and yet year over year, CMS is just accepting. So, if we look at whether it's the RUC's fault, the AMA's fault, I don't think it's anyone's fault in particular. I think it's the reality that we haven't invested in the infrastructure needed to build a more empirical data set to determine how these should be valued. And secondly, we haven't kind of calculated the importance to population health and how setting these rates at a certain level creates incentives for the doctors we create, which has implications for population health. And ultimately, now we're in a place with a primary care shortage where we need more primary care doctors, and that's frankly critical for the United States population health in the midst of a chronic disease epidemic. And so we have to take that into account. And that's something that we just haven't done a great job at. I think this CMS under this administration has been more ambitious than others, but we have a long way to go.
So, just to summarize what you said so far, the RUC is part of the AMA and the American Medical Association, which surveys its stakeholders, its members, to get this data. But there have been a lot of concerns about this data and its accuracy that the government, the CMS, then largely relies on to set rates without looking elsewhere. Are there alternatives to this data coming from the American Medical Association?
Yeah, so there's a couple arguments that can be made, particularly when we look at solutions. So if the fix that is needed is for the AMA to have less of a role in determining the ultimate rates that are set, like particularly when it comes to being able to choose how much a specialist should make for a service versus a primary care doctor, when the body itself is dominated by specialists. I think that's a main concern when it comes to conflicts of interest. But what the solutions look like is sort of a very much open conversation. One of the things that CMS is currently doing, they've suggested that they're looking at more ambitious changes, such as like moving to more empirical data sources rather than asking the AMA to do these sort of annual surveys and then relying on those surveys itself. One of the things that CMS has already done in this most recent physician fee schedule is what's called an efficiency adjustment. Because the physician fee schedule is budget neutral annually, designed to be budget neutral, if you want to pay primary care doctors more on a service by service basis, you necessarily have to pay other doctors less when it comes to like the rates for each service. And so one of the things that CMS has done is essentially made an adjustment so that the areas of medicine where they think have had efficiency gains with modern technology, particularly the services that are less cognitive and more procedural, those services kind of got a hit. We're talking like 2-3% relative to primary care, which received like a 2-3% gain based on this efficiency adjustment. So that's one way that CMS is trying to do it. I think that's beneficial, but ultimately the flaws in the design are structural, and so I don't think the long-term solution is just to continue to do these sort of like small adjustments. I think ultimately we need to have correct and empirically accurate data to determine how each service should be valued.
Would that empirical data come from someplace other than the American Medical Association, or is there a way for the RUC to still oversee this?
Ultimately, the question is, should doctors be at the table? I think the obvious answer that most folks would agree on is yes. In some way, of course, the American Medical Association doctors should be involved in this process. The question is, how do we involve them in a way that leads to more accurate data, but not in a way that creates these sort of conflicts of interests? Ultimately, it's about creating a more independent kind of committee that can oversee this and getting better data. I think those are the two things we need. The degree to which the AMA should be involved in that, how we use AMA surveys, whether they should be adjusted. I think there's a ton of open questions that need to be hashed out. And I suspect that over the next 2 to 3 years, those are conversations that we'll be having. And I believe that with those things, you'll close the gap a little bit when it comes to what specialists get paid versus what primary care gets paid.
I think that completely makes sense. And you wrote an op-ed in the argument saying that this is something that is a bipartisan issue uniting some unexpected and strange bedfellows like Elizabeth Warren, RFK Jr., and Mehmet Oz all agree that looking for better data through something like an independent commission is necessary to then advise CMS with the right information for physician compensation.
Yes, and I think we don't want to make it overly bureaucratic in the sense that we just create all these commissions and all these committees who look into it and then nothing ever happens. And so
Right.
it is important that CMS continues each year in the physician fee schedule to make ground on this, whether it's through some sort of adjustments, what they call efficiency adjustments, to change to make it less procedural. But ultimately, at the end of this administration, I think based on their ambitions, we would want to see some sort of proposal, something concrete that is able to replace what the RUC currently does. Because honestly, at this point in 2026, we shouldn't rely on low response surveys with high variance to determine how much Medicare, the largest payer in the entire country, how they set those rates. We at this point with, even if you want to just look at how AI has changed over the years, we should have a much more objective way of determining value here.
One of the things that I'm still stuck on is the formula that goes into these relative value units or RVUs and how it doesn't take into account the long-term effect on patient outcomes and value. For example, we have so much empirical data showing that primary care saves lives. Like if you
Mhm.
have a regular primary care physician who you can see over time, you will have better health outcomes. You will have better outcomes with chronic disease management. You will get important preventative care. But trying to capture the value of a 30-minute primary care visit within that long-term relationship, I think is a bit more challenging. What are your thoughts on how we can capture those episodes even within this bigger story?
Yeah, the current issue is that we sort of reward single high cost procedures, right? That's kind of the way the system's designed. And like the management, these are what's called E&M codes, evaluation and management codes. These codes are not, they're not valued at a rate that would make sense for how important they are to the long-term health of the clientele of patients. And so there's things that they've tried to do. There's a recent code where they essentially added a new evaluation and management code that primary care doctors are supposed to bill that would be billed at a significantly higher rate than previous evaluation and management codes were billed at. And somehow during the process over the last year or so, I think 2 years since it was released, specialties were able to hijack that code and actually made more money off of it than primary care doctors did. And it's a really good example of the pitfalls even when you try to value primary care better, the core problem is often more structural and requires, I think, more ambitious reform. And so to your point, that would require an actual change to the way RVUs are calculated in the first place. Now, how you do that in terms of ensuring that it accounts for population health, I think is a really difficult question. I think one way to do it is to, make a part of the payment, a part of the formula needs-based. You could do that through making it higher payments in areas with shortage for that particular specialty. Versions of that have been suggested over the years. I think that makes a lot of sense because it is an objective measure of how valuable that physician is relative to other physicians in that in other specialties for that part of the country, that region, whatever kind of statistical area you want to use. I think that's a sort of proven way to improve this. But once again, when you do things regionally, we have a history in healthcare of hospitals and other entities reclassifying themselves as urban or rural, or then taking advantage of these sort of regional distinctions. It has to be designed really well, and it has to account for all of the ways in which these payments tend to get gamed.
And I think the last point is going back to that RVUs don't fully capture the administrative work of primary care and taking into account or finding some way to compensate for all the work that happens outside of the face-to-face patient visit, which is how traditionally primary care has been funded. So, for example, I might see a patient during a 30-minute visit. I'll order some blood tests. Later that day, the blood tests will come back through my electronic portal. There might be some things that are abnormal. I will either send the patient a message about my thoughts on follow-up or even give them a phone call after hours. And none of that is currently captured in the RVU payment model.
Yeah, and it is one of those things that I think a lot of folks are aware of how this needs to be adjusted in light of modern medicine, where you have doctors that are now direct messaging patients using these platforms. That kind of work needs to be accounted for because ultimately it's the burden is borne by primary care physicians who are probably doing more contact with patients, right? We need to be valuing these relationship-based care models that allow for consistent communication, that allow for long visits. And right now, all the incentives are built in the opposite direction. You want a shorter visit because you need the time. And, being able to respond and message and all the different things that patients may want out of their relationship with their doctor, those things should be valued in the way we pay for it. And as you point out, it's just not the way it's currently designed. And so baking that actually into the formula, I think is just a way to modernize medicine in America, honestly. We need to be thinking through of not just what's best for patients, but what just makes sense in terms of technological improvements. And we obviously want efficiency to drive down costs. I just don't think primary care is where we need to be saving money. I think there are plenty of other areas in healthcare.
I want to talk about some other things that you've written about that the American Medical Association or the AMA has done. I would say without malintent, but just because they're serving their members who are primarily specialists to then disincentivize primary care. You've written about some things they've lobbied for, like adding more years of training in residency in order to become a practicing primary care attending. You've written about how they've lobbied to expand subspecialty options after residency. Can you say more about this and how the AMA has perhaps unintentionally disincentivized people going into primary care?
Yeah, I think going back to the origin of like our current residency system is important. So before we actually had everyone going through at the minimum 3-year residency, you actually had a system where to become a general practitioner, a primary care physician, after you got your MD, you only needed to do, in some cases, a 1-year internship before you could become a full, unrestricted licensed primary care doctor. And that's remarkably similar to how Europe is currently doing their GPs, where you don't necessarily have to do the same amount of residency training. And it's not to say that every specialist has to do the exact same amount, but there is a minimum and there is a residency requirement if you want to be a practicing licensed MD. And it seems obvious at this point that there should be opportunities for primary care doctors to build competency without necessarily having to go through the same exact pathway as other specialties. And so there's now a lot of medical schools that are opening up these sort of shortened accelerated pathways for primary care graduates, which I think makes a lot of sense. There's even movement on the Hill and in other places, people talking about shortened education timelines for those going into primary care. But as you pointed out, the AMA was heavily involved in the early days of trying to essentially put everyone through the same exact pathway. But it's important to note that it's not that primary care doctors opposed this, right? Primary care doctors at this time wanted to be considered, more elite and to be kind of on par with other specialties. And so, they welcomed the idea of being lumped into the same exact minimum residency requirements. Now we're at the point where, looking back, I think primary care doctors are seeking opportunities to improve the incentives of going into their field.
So currently, in order to become a primary care physician, you have to do, this is what I did. You have to do 4 years of medical school, 3 years of residency. So that's 7 years of training. I happen to do a fellowship after that. That's optional. Most primary care doctors don't do that. Now people are looking into options that don't just shorten the residency training to 1 year, but perhaps kind of group all of that primary care training earlier on into medical school. I will say, I don't know if I needed 4 years of medical school to practice the way I practice now. Having gone through this, I certainly think there were areas that could have been condensed if you know what kind of specialty you're going into down the line. And I had a ton of training in things that I ultimately didn't end up practicing. I think many PCPs now would welcome a shorter training pipeline if they come into medical school knowing that they want to practice primary care, and that would actually incentivize more people to go into primary care and stay in primary care.
100%. And I do think this is a sort of specialty by specialty in the sense that, currently you have a lot of folks going into primary care, but they're doing it through the internal medicine route. And, internal medicine has changed enough so that now, the vast, vast majority of folks who go into internal medicine are going to end up working in hospitals, or they're going to subspecialize or not do primary care over the course of their career. And so I think there's been a lot of changes in primary care that might warrant a reconsideration of what is primary care, what specialties constitute it. And when we try to create sort of these accelerated pathways for primary care, we want to make sure that those folks practice primary care in terms of what's the intention of the accelerated pathway. And so I think there's a lot to consider policy wise of what these accelerated pathways look like, who should be considered for them, and how do we ensure that when we create subsidy, whether it's time or financial, to improve the incentive of going into primary care, are we targeting the right folks and making sure that they actually practice?
It's the perfect segue to talk about residency funding and how that influences the choices of then graduating residents. So, a lot of people don't know this, so I will say it is Medicare that primarily funds what's called GME or graduate medical education, which is a required residency that you have to do after medical school, plus or minus a fellowship. So the government is paying hospitals to train residents. And kind of like RVUs, there's this complex formula that the government uses to figure out how much hospitals should get in order to train residents. And I want to talk about that. Can you give us an overview of what goes into GME funding? And then we'll get into how that influences specialty choice.
Yeah, of course. So every year, Medicare, through their GME funding program, distributes around $20 billion. It changes every year. I think it was a little bit over 20 billion more recently. Around $20 billion to teaching hospitals to train residents. That funding is distributed in two different ways. One is through indirect medical education. This is 75%, three-quarters of the 20 billion, which it's not what you would expect. The funding is actually sort of calculated like a restaurant tip. Essentially, every discharge that a teaching hospital does, the IME fund essentially reimburses as a portion of that discharge full amount. And so what it does is it incentivizes hospitals to keep patients inpatient longer hospital stays and more expensive hospital stays, they're going to get a larger indirect medical education payment from Medicare. The other 25% of these payments are direct medical education, and it's more designed as a sort of a standard reimbursement for the direct costs of training residents, the time of the supervising physicians, the facilities themselves. And that is largely determined based on hospitals' reported costs of running the residency program that they reported to Medicare in the 1980s. That is yet to be adjusted. And so that direct medical education component, the 25% of the funding, it's sort of locked in kind of these historical cost baselines where you have a lot of hospitals now that maybe didn't have as many residents. And because the cost reporting is largely based on both sides, it's largely based on your sort of your resident to bed ratio. Essentially, larger programs, more residents is rewarded. Longer inpatient stays, more expensive services are rewarded. And this is over time disincentivized smaller and more rural residency programs. There's one more key component to this, which is that the reimbursements are not designed for outpatient procedures. So it's exclusively to inpatient. And as a result of that, the over time, graduate medical and so education just has sort of disadvantaged primary care inherently. I will say that sort of this was originally intended as a temporary way to reimburse these hospitals for treating Medicare patients. So Medicare was like, oh, if these residents are going to treat Medicare patients, it makes sense to reimburse them. And in some of the a part of the formula is still connected to the amount of Medicare patients that a teaching hospital sees. But, I think there was maybe this implicit intention, and you can go back to the history books and see this, that, it was both temporary. And if it wasn't temporary, I think there's an expectation that maybe private insurance companies would also reimburse these teaching hospitals similarly.
And they never match that.
And they never matched that. And so Medicare's sort of investment in this has sort of grown over the years. And because of that, in 1997, they actually capped the money that they're giving at an institutional level. They added a few thousand slots and during COVID, but it's been basically set at 1997 levels and locked in at 1984 cost baselines. And so the payments themselves are really outdated and don't really reflect the costs of training residents today at all.
We're going to get back to that 1997 cap, but before we do, I want to just go back to the breakdown of how GME gets funded, that direct and indirect breakdown. So my understanding is graduate medical education does include things like resident salary, resident benefits, overhead, right?
Yes.
And so I found some data saying that on average, Medicare pays for GME. It's $112,000 to $160,000 total per resident annually. And yet the average resident salary is $60,000 to $75,000. So it is, like you said, it's less than half of the total funding that's going to graduate medical education is going towards resident salary, which seems to me like then this large portion is being captured by quote unquote everything else. Like, what is that everything else? I mean, some of it is benefits, some of it is overhead, but a lot of it seems to be those indirect costs. And I wonder if, you talked about ways that this funding model is outdated, but I wonder if one of the ways it's outdated is that hospitals are not being completely honest and transparent about the revenue that residents generate rather than the fact that residents cost money because it's still a training program.
Yeah, 100%. I think one of the misconceptions surrounding residency funding in general is ultimately that every hospital needs this subsidy, right? In order for us to produce doctors, we essentially need to subsidize these hospitals. It's clear that the hospitals make money off of these residents. They obviously pay them really low salaries relative to the value that they're bringing. And the subsidy itself is I mean, it's a subsidy. At this moment, it's not exactly a way to just it's not a reimbursement in any real sense anymore. Particularly the indirect medical education portion, which has grown as a percentage of total GME, because obviously the cost of these services has grown, right? And when you have more specialists performing more expensive services, and those services, even, this still comes back to how we set some of these rates, right? If we're reimbursing services continually, higher relative to primary care, you have these inpatient discharges that allow for a pretty hefty reimbursement because the funding is not tied to anything in particular. It's just like I said, it's like a restaurant tip on top of the discharge. It's become a really important source of funding for hospitals because then they can essentially use that for whatever they need, particularly for capital investment, for anything else. I mean, a lot of these academic medical centers, I see them advertised essentially everywhere. We have Super Bowl ads by some of these large hospital systems that get these reimbursements. So there's a lot of things that they can use this extra money for. I think another part of this, I mentioned the 1997 cap. There is realities of being able to create the slots. So there is necessary capital investment needed if you want to build a new medical school, if you want to open a bunch of new residency slots. And I think that's essentially what's been more difficult for the smaller and more rural programs since 1997. You now have a situation where small and medium-sized residency programs do not nearly fund slots above their cap at the same level that large institutions do. Large institutions have the capital investment to be able to essentially add slots and not get reimbursed for them anymore by Medicare, whereas smaller and more rural residency programs do not. And as a result, since 1997, you have more and more Medicare GME funding going to large institutions in the Northeast, going to states like New York and Massachusetts at the expense of a state like Texas, even. Obviously, a large state with a growing population, but is not able to capture this funding because their programs aren't able to expand in the same way that others are.
So going back to that cap, my understanding of where it came from was that there was a report that was commissioned by the Department of Health and Human Services that actually warned of an oversupply of physicians and that it was an oversupply of physicians that was driving up healthcare costs, which today I think there's been, mountains of empirical evidence is saying the opposite is true. Is that where that cap came from?
Yeah, I think there's always a lot of different reasons why Congress can pass a law, and it takes a lot of work. So they believe there was good evidence to suggest that an important way to reduce healthcare costs was to cut the sort of open-ended flow of funding that was coming from Medicare GME at the time. And the reality was like Medicare GME was contributing to a significant increase in our doctor supply at that time. And it was, it was there to meet demand for care. And we became scared and concerned that we would somehow, and this is sort of, it gets back to the core arguments related to healthcare costs, right? Is it utilization or is it prices? And at the time, this was sort of built on the idea that, you can go all the way back to Romer's law, which is sort of the idea of like a bed built is a bed filled. The concern that doctors will always sort of manufacture, induce utilization, even if it's not necessary. And that was sort of at the core of this. It was the idea that, we need to stop this flow of money because we're going to keep producing doctors even though we don't need them. And it was unfortunate because it kind of created the situation where these smaller residency programs didn't have the capital investment cash they needed to be able to grow and to expand in areas where doctors were more needed. Because data shows that the doctors' practice where they do their residency. That's when a lot of folks, as you know, are planting roots. A lot of folks are getting married. A lot of folks are trying to start their life. They're, 4 years out of 4 to 7 years out of school. We need to be creating more opportunities for folks to plant those roots in areas where we need doctors. And GME funding is sort of, instead of serving as like an active tool to address workforce shortages and disparities, it's become like a passive amplifier of the problems in the system. It is, allowed, as services became more expensive, they got larger reimbursements. As these large institutions in the Northeast grew, they got more money from Medicare, and we left behind the areas of the country that need the doctors more.
So the reality is, last year it was nearly 10,000 medical graduates failed to match to a residency program, meaning they graduated medical school, they have an MD, but without residency training, they are unable to then go into practice as attendings. Do you think we have to just fundamentally remove that 1997 cap?
One of the good things it would do is it would once again open up a pool of capital investment funding for smaller residency programs. But what it won't do is deal with the structural flaws in the way the formula is designed, like basing the indirect medical education payments entirely on inpatient, right? Or using a resident to bed ratio rather than, actually how many patients are being treated. I believe we should reform the underlying formula probably prior to opening up this stream of money in the same way again. And there's another kind of interesting way that I think the 1997 cap has frustrated smaller residency programs, which is you have some programs who had visiting residents at one point without having a residency program, and Medicare's GME counted those visiting residents as towards the cap, and they haven't been able to create a program because they are technically at their cap. So that's one of the, there's sort of tweaks that need to be made to the cap for sure. But ultimately, I think the best solution is to change the way this money is calculated. And Congress has the opportunity to do that. We can reform how GME is done. And in fact, just last month, the House Ways and Means Committee had a hearing on GME where all of these issues were amplified. The entirety of the majority side of Ways and Means Committee was highlighting all of these problems in GME funding, and the residency managers were testifying to these problems as well. And so there seems to be growing recognition of the need to reform the underlying formula and not just look at the cap.
Right, rather than just opening up this unlimited blank check. And I think requiring or asking for more transparency and accountability from hospitals about where that indirect funding is going. And like I mentioned, the revenue that's being generated for hospitals, that residency is not just a cost sunk, option for hospitals, that residents hour by hour are actually the cheapest paid employees of the hospital. That's unfortunately led to some situations where residents are, subjected to very long hours and not great working conditions because they're just seen as cheap labor and not an investment in future attendings. So I think changing the formula, but then again, also being more transparent about where that money is going and frankly, what percent of that formula goes to resident salary, which is currently very low.
I think that's exactly right. And, I would even be in favor of adjusting and ensuring that residents are getting paid more, particularly, in specialties that we need. I think we need to use a stream of funding as a means to address workforce problems. And right now, you have these $20 billion we're giving out annually to these programs, and none of it is harnessed in a way that actually is useful for patients. I think maybe when it was first created, it was sensible to design it this way at the time, but we have just been unable to revisit it. There's some folks who would argue that we don't need this money at all. We need to just save it and, use it to counteract the debt. And I think that's likely misguided. I think ultimately, when you have a pool of funding and you have these formulas, we should try to figure out a way to harness it and actually use it to address workforce disparities. We have a paper coming out that will sort of like highlight all of the various options that Congress has to change these formulas and actually redirect it towards shortage areas and specialties of need.
And redirected away from, like you mentioned, inpatient care and more towards outpatient care. Because
Yeah.
I will say the residency education directly reflects how it's funded. So the vast majority of my residency was inpatient. It was taking care of patients in the hospital, whereas I ultimately ended up practicing 100% in the outpatient setting, and my training didn't reflect that.
Yeah, 100%. And well, frankly, not just like think of this as a workforce thing, but just think of better trained primary care doctors in addition.
Right, exactly. I want to talk about another place where we can increase physician workforce, and that's international physicians. So these are folks who have completed their medical education in another country and are fully trained attending physicians, meaning they did all of their post-medical school education and training as well, like residency and fellowship. But when they come to the United States, they are required to redo a residency.
Yeah, so there's essentially two categories of international physicians. One is IMGs, International Medical Graduates. That is sort of a broad category to describe essentially anyone who did any sort of training overseas and then practice in America. That doesn't necessarily mean an international medical graduate does not necessarily mean that they did residency training or they did practice as a licensed physician overseas. And then you have another group, which what we refer to as internationally licensed or internationally trained doctors, ITPs or ILPs. Those doctors are those who have already done their residency and done their residency and practiced for a certain amount of time as a licensed physician in another country and then moved to the United States. Those doctors are the ones that are at a unique disadvantage because they will move to the United States, even sometimes not as in their role. Oftentimes you'll say your husband or your wife gets a job in the United States and you're a practicing doctor, you'll move to the country not on even a visa that is indicated for that type of work. And then you'll arrive in the States realizing that the state you live in requires you to do a residency again, either in the US or Canada, prior to applying for licensure in your new home state. And that is a problem that still 25 states have, around half of states. In the last 3 years, the other half of states have reformed this. They have essentially created what we call an alternative pathway to practice, which is a supervised period of time where, assuming you can prove that you practiced in another country, every state sort of has a unique requirement. Sometimes it's you need to practice for 3 years, you can't be too far removed from your last time you practiced with your license, etc. All you have to do is apply in your home state and then practice under supervision, not direct supervision, but indirect supervision by another physician. And then ultimately, it will automatically transition to a full unrestricted license. And it's frankly transformational to the physician shortage problem because, like you mentioned, 10,000 folks, most of which were international graduates, did not match last year to a residency program. A lot of those folks had already done residency. We don't know the exact numbers because we don't track this very well. And so states are recognizing that this is a common sense solution, and it's become a major deal. And now you have a lot of doctors practicing under these licenses over the last year.
I will say that I have supervised as an attending my fair share of ITPs, so international physicians who have completed all of their training elsewhere. And it's a little awkward because it's like an attending supervising another attending. They already know how to practice medicine. It makes my job really easy because they require a lot less supervision. But it seems like they are really going through the gauntlet of something they don't have to do and just delaying when physicians can practice.
Yeah, and there's even some, states. I was recently in Pennsylvania, working on this issue at the State House in Harrisburg, talking through with lawmakers and other groups. And, there's even folks in Pennsylvania that argue that, we don't need to create even the supervisory period. We could either shorten it or just allow doctors to practice who we know have been practicing and don't have any issues once there's an entity like a facility that wants them, right? Once a facility says, "Hey, we want to hire this doctor," they already go through a lot of work to ensure that that doctor is going to be good because they're the ones that ultimately deal with any sort of liability, med malpractice claims. That is ultimately on the employer, right? And so, oftentimes lawmakers and state boards will definitely go over the top to ensure quality, but we also have a very robust system for ensuring competency that employers are ultimately responsible for.
I mean, I think without having any data to back this up, but just based on my experience working with these physicians, I probably would favor some middle ground of a short supervisory period, not because the medicine is different. It's like medicine is medicine, regardless of where you practice, but learning the particulars of how to navigate the US healthcare system, I do think requires some on the ground training, but certainly not an entire residency.
Yes, I mean, one of the classic examples is how long does it take to learn Epic? Like that's something that the EHRs in general is something that may be an adjustment for an international doctor who may be coming from Britain's system that's extremely different. And in general, like you have a lot of differences in region to region in the US. Even when a doctor moves from Philadelphia to rural Missouri, you're going to be, if you're an ER doctor, you're going to be getting a lot of different kinds of injuries. You go from mostly gunshot wounds to, we always use the example like tractor accidents. Like it's not something you would probably see in urban Philadelphia. And it's important that as lawmakers, as state medical boards, put some trust into our hospitals, our federally qualified clinics, our independent primary care clinics, our ERs to be able to manage these situations because ultimately they're very good at it.
Finally, I do want to talk about this op-ed you wrote for The Hill. This is switching gears a little bit, but about funding direct primary care and how that's yet another pipeline to get more folks practicing primary care and staying in primary care. So, just to define it, we actually went into some detail with this in our first podcast episode with Dr. Lisa Rodenstein. But direct primary care is a relatively newer model of primary care that essentially cuts out the middleman. It cuts out insurance companies. And by having patients typically pay an annual or a monthly fee like they're going to a gym membership, it lets the primary care doctor cap at a much lower total patient volume in the hundreds compared to the thousands, and remove some of these incentives that just say more patients, more visits, and just provide good relationship-based primary care. So I think it's a model that a lot of people are very excited about. Typically, like I mentioned, it is patients who are paying that monthly or annual membership fee. And the concern is that this leads to inequities, right, of who can actually afford direct primary care. You wrote an op-ed, though, talking about this bipartisan bill on Congress that's exciting called the Medicaid Primary Care Improvement Act, which would essentially allow states to contract directly with direct primary care, meaning in practice, Medicaid is paying for direct primary care rather than patients paying that monthly or annual fee. Is that right? And why is this so exciting?
Yes, no, you explained it perfectly. It's a rare situation in DC where you're pushing a piece of legislation that's one page, right? All it essentially does is currently, if a state Medicaid plan wanted to create an arrangement, right, with a group of direct primary care clinics or even just one direct primary care clinic, they would have to file what's called a Section 1115 waiver. The waiver process, both the application for it and the time it takes to get an answer, is notoriously fraught. Takes a long time, can be very difficult, even when in situations where you have an administration that even may be supportive. It's just it can be a bureaucratic nightmare. So all the bill does is essentially waive this requirement to file for this 1115 waiver if a state wanted to create these partnerships. It essentially creates a time and financial incentive for states who want to do this. And just to explain briefly how it would work, essentially, a state Medicaid plan could find, oftentimes centered around a city, you may have direct primary care clinics that are in a group owned by the same entity. You could partner with them, negotiate a rate for like a per patient monthly rate. I suspect that in these negotiations, you will see either similar or even lower, per patient monthly rates. Right now, patients tend to pay around $100 for DPC on a monthly basis. In some parts of the country, you could see really, really a lot less. You could see like $50, $40. Others you may see a little bit higher depending on cost of living. But Medicaid would then pay that rate or whatever rate's negotiated. And Medicaid patients would hopefully be alerted, make clearly communicated that this is an option, and be able to, for the first time, get routine primary care without wait times in, a independent primary care clinic setting. And those visits are going to be 45 minutes, going to be 30 minutes. That's kind of the hallmark of the DPC model is no wait times, long visits, relationship-based care, longitudinal care. And it's the kind of thing that would allow Medicaid patients who typically would have to either go to the hospital ER to manage, say, diabetes, and get their medications on time and deal with any of the complications and symptoms that come with diabetes management, or go to the urgent care, which oftentimes are definitely not set up for that kind of longitudinal care. And I think that has transformational long-term implications for how we care for Medicaid patients. Obviously, DPC is a smaller model, it's burgeoning, it's new. And so time will tell how this will all play out. But I think the potential is truly transformative.
I feel like this would be a slam dunk. Every physician I know who has gone into direct primary care just, sings the praises of direct primary care in order to be able to give those longer visits to patients, to practice primary care as it was truly intended, relationship-based care, and just having a smaller panel that allows them to develop those relationships with patients. So this is a bill on Congress that has not yet passed into law. Is that correct?
That's right. Yes. So the bill passed the House last year, which is great news for its future because any bill that's already gone through the committee process just makes it more likely that it'll go through it again because the committee knows that we've already done this once. So our hope is that we could see it progress this year. This is a bill that's actually supported by the administration. Robert F. Kennedy Jr. has endorsed it in a committee hearing. And it also has bipartisan support. And on the House side, you have a lot of Democrats that are on board for this kind of proposal. It's been introduced in a bipartisan way in the Senate as well. I even speak with Medicaid directors in the states who want to do something like this, who say that if this bill passes, they would be open to piloting this concept. So I believe that we'll get this done at some point. I'm just hopeful that we can do it sooner than later.
You're making me very optimistic. Um,
I try.
so I want to summarize a few things that we talked about. So overall, we have too few primary care physicians in this country, and we have too few primary care physicians practicing in parts of the country where they're most needed. One piece of data that I didn't cite yet that you had actually written about is in the 1960s, half of private practice doctors were in primary care. And then today, primary care physicians make up just 24% of the total doctor workforce. We talked about a few ways that policy can incentivize more doctors to go into primary care and stay into primary care and practice where they're truly needed. We talked about RVUs and a payment model that currently kind of overcompensates specialists at the expense of primary care services and where that's coming from. We talked about the training pipeline, so not enough medical funding for residency, reflecting outpatient care and reflecting rural population that needs this care. We talked about international physicians and a quicker pipeline to getting them to practice as attendings. And we talked about new ways to fund direct primary care. So you write all of these compelling evidence-based reports, suggesting these clear reforms to the government. So pretend that I am a sitting member of Congress with an open ear. Help me prioritize. How do we get more doctors where we need them?
Yeah, that's a great closing question. I think the one thing that I always come back to is ultimately it's about the market sending the right signals, the right incentives to prospective doctors and current doctors, right? So I think in terms of how we prioritize this, we have to point our fingers directly at Medicare because this is both the reimbursements we have on a service by service basis and the $20 billion in annual GME funding. These are the levers to have large outsized influence on the makeup of the physician pool in America. And right now, they're being totally underutilized for this purpose. They're not used in a way that actually results in needs-based allocation or directly dealing with workforce challenges that patients are seeing, the shortages that they see in primary care and psychiatry and other specialties. So ultimately, it comes down to starting out with the basics, which is we have to reform the underlying formulas that contribute to this. And so that's both the RUC's involvement in how we pay primary care doctors and the way GME funds are distributed across the country. I think that Congress actually has the authority to do those things. The other things we talked about, a lot of that can be done at the state level in terms of licensing and other ways to open up these positions. But I think if I'm talking to Congress and I'm looking at sitting senators, sitting members of Congress, you have control over some of the ways in which Medicare divvies out these funds and can direct the secretary to reform this. And I think that must come first.
Lawson Mansell, thank you so much for joining me on Hard Medicine.
Thank you, Alana. It was great.
Thank you to founding member Matthew Beckman. If this conversation helped you see medicine differently, subscribe to Hard Medicine and share this episode with someone who should be part of the conversation.